this afternoon. I'm giving just a few short introductory slides on the Division of Clinical Research Network. And then we're going to have a wonderful panel who will be looking at questions and make this more interactive and fun. So, as you can see, the DCR, the Division of Clinical Research Programs, are available across all the phases, starting with clinical trial readiness, going all the way to comparative effectiveness. Dr. Hartman is an expert on that in the audience, and I have the dissemination and implementation PR. And you can see all the networks, which I'm going to focus on today. And in addition, there are biomarker discovery, outcome discovery, and clinical trials embedded in natural history studies, and cognitive elements that are all covered. As you can see here, this is the early portfolio of active grants, and basically, clinical research is only 10% of the entire portfolio at NINDS, so it is a small but significant part. And most of the smaller branches represent one trial. As you can see here, represents the majority of our trials. And this is the efficacy clinical trials portfolio. And again, there are a number of different diseases represented: epilepsy, Parkinson's, muscular dystrophy, pediatric, and traumatic brain injury. And again, stroke has the majority of the phase 3 trials. NINDS networks span all the phases, and from exploratory phase 1, phase 2, phase 2-3, adaptive designs, and phase 3 trials. The first network was NET, that was established in 2006 through 2018, and it was established to do acute care research, primarily efficacy trials. The next was NeuroNEXT, 2011 to the present, and was initially initiated as phase 2 network with biomarker capability. Then StrokeNet, which basically studies all the different phases of stroke, from preventative, acute care, intervention to rehabilitation, and is primarily in the phase 2-3 space. And SIREN, which last year was, actually 2 years ago now, was funded and basically was a morph of NET to include NHLBI and cardiac, hematologic, and respiratory diseases. And finally, our newest network is the HEAL network, which basically addresses non-addictive pain. Now, I did want to make a comment about the Rare Disease Network, which is primarily or initially funded by NCATS, but NINDS as well as other ICs contribute, and we have a couple of members in the audience, Dr. Benatar and Dr. Shah, who are going to speak later about biomarkers that they've developed through these networks. But I'm going to focus on the NINDS networks for now. So the structure initially started out as the hub and spoke model, and basically the hub was a clinical site that could do the studies and was given infrastructure money, and the spokes were clinical sites that could either do the studies or recruit subjects into the hubs where the studies could be done. And in this model, we also have 2 different coordinating centers. So I know sometimes networks have one coordinating center. We have a data coordinating center and clinical coordinating center in all of our studies. And then NINDS and the trial PIs work with all of these. And I just wanted to emphasize that the trial PIs can come from within the network or outside of the network. And the idea here was to increase the trial quality, to obtain a balanced portfolio, have stable infrastructure and capacity, and to have coordinators who are dedicated to this, improve data sharing with a single data center, and fostering the use of our common data elements, and we could manage competing trials in the same diseases, and also coordinate with others like industry, nonprofits, international partners, and hopefully train the next generation of clinical trialists. And that's why you're all here for the clinical trials methodology course. Okay, so now so it's time for the young panel. I'd like to have you introduce yourselves. I'll bring you the baton. And I have a few questions that I thought of, but I will let the audience start.
Okay, good afternoon, everyone. I'm Valerie Durkalski, and I'm a biostatistician at the Medical University of South Carolina. And the group that I'm part of is the data coordination unit there. And so we work, my team, Sharon and Renee, some of you have met, they're also part of our teams. And we write grants to be the DCC, or the Data Coordinating Center. So we were fortunate enough to be, to successfully get the DCC for the NET, which started back in 2006, and then we competed to be the DCC for SIREN, which is the new existing network. So we're doing that right now. We also are the DCC for StrokeNet. So lots of good experiences there, so I'm happy to share that as we go through the panel discussion.
Chris Coffey, as you heard this morning. I'm a biostatistician here in Iowa, and at PI, the Data Coordinating Center for NeuroNEXT, which you heard a little bit about this morning. Do much of the same things Valerie mentioned for StrokeNet and SIREN. We work closely with the Clinical Coordinating Center at Mass General. Marianne Chase is in the back. She's here representing that. I think she works with me at the DCC. There's several others involved. So the one difference from NeuroNEXT versus the others, as I kind of alluded to this morning, is it doesn't focus on a specific disease. NeuroNEXT kind of covers all the diseases that don't fit under the portfolios of the other networks that are in the United States.
I'm Will Meurer. I'm in the Departments of Emergency Medicine and Neurology at the University of Michigan. The University of Michigan is where the Clinical Coordinating Center for the SIREN network is. It's a multiple PI structure. Bill Barson, Robert Silverblight, and Cliff Calloway from Pittsburgh are the multiple PIs. I'm a co-investigator of that. I was also a co-investigator on the preceding network. SIREN is focused on the early care of neurology and heart, lung, and blood emergencies. In that it's a collaboration between NINDS and NHLBI. In contrast to NET, which focused exclusively on late-phase trials and neurological emergencies.
Good afternoon. I'm Coffey. I'm an emergency physician also at the University of Cincinnati. And I sort of wear different hats in terms of the different networks. I'm PI of multiple PI, but lead PI on one of the phase 3 StrokeNet trials called MOST. Prior to that, I was hub PI for NET hub, and currently serve as hub PI for a SIREN hub. And so I kind of bring the perspective of, I think Laurie's given the talk on being a good site PI. Bring the perspective of having served as a site PI, hopefully a good one, on multiple trials in NET and now in SIREN, as well as the PI of our ongoing trial
I'd like to see what questions the audience has, first of all, and then I have my backup questions, and I even have more slides that we haven't covered. We're going to have things. Thank you.
Thanks. Obviously, I'd like to address this to all of you. I guess when I think about these networks, they seem like something that's going to be useful for me at a much later stage of my career, as we're here in this course working to develop phase 2 and maybe phase 3 trials. I wonder whether and how I should be thinking about relying on the resources that all of these networks have. Is it something for us, or is it just something to remember in the future?
I think Dr. Coffey would be the best person as the NeuroNEXT representative, since there are more diseases at earlier stages being studied in NeuroNEXT.
Yeah. So the other networks do phase 3 and phase 2. studies. NeuroNEXT is strictly a phase 2 and a biomarker network. So in many cases, also since it covers wide ranges of diseases, in terms of career progression, it's probably closest for many of you in terms of where you might fit relative to the other. And we talked about this a little bit in our internal group. Really, what would be a progression that where NeuroNEXT might fit in the future of many projects is if you're working on something, maybe you're working on a single site protocol, just based on the resources and to try to get something going. You know, promising findings there. The next step is then to look at a phase 2 multi-site type protocol. That's where NeuroNEXT could potentially fit. And one of the objectives of the course is to try to develop protocols that could progress in that way. And part of the appeal of NeuroNEXT, but all the networks in general, for many of you as you progress, is it's really hard to pull all the pieces to do a multi-site clinical trial together from scratch. Even if it exists in your institution, sometimes it's hard to pull all of that together. I think that's one of the appeals of the network, is all of that infrastructure is there. And so if you come in, you've got a lot of help pulling that together. And with many of the studies in NeuroNEXT, we've had, differences. We've had established investigators who have led studies we've done. We've had pretty junior investigators who have led studies. And I think for the junior investigators, it's particularly helpful because one of the goals of the networks, particularly NeuroNEXT being in the phase 2 space, is that if someone has a good idea and it looks like it has promise, the inability to kind of pull all the resources together that might keep it from moving forward is a barrier that we've tried to solve with the networks. The idea is, if it's good science, regardless of where somebody is, they can tap into the network and build the infrastructure so that the grant application and the funding of the project kind of lives or dies on the science and the justification of doing it. So I think it's probably not as far from where you are as you think. It's not probably in the next year, but potentially, 2-3 years down the road. And there's some talks with, at least tomorrow, with one of the former students who's moving in that direction, so you can get a sense of how something like that.
So yeah, I would just also say that, keeping an eye on, it's sometimes good to know about the networks because if you have a study that's on a trajectory, SIREN also does tend to cover a lot of neurocritical care stuff in its portfolio. Knowing what sort of evidence that network thinks might be motivational towards making the next step to a multi-center trial can be helpful to make sure that you're designing something that could address the potential gaps in knowledge that are going to be between where you are today and where you would be in terms of doing a multi-center trial.
The only other thing I wanted to add is, as we all know, designing our studies takes some time. So starting, even if you are 1 or 2 years out, having those conversations now, reaching out to the network saying, I have a potential idea. Because we've worked with some investigators, particularly junior investigators, where it took 2 years for us to get the grant in. And that's fine. That's not an issue. And that's, as we mentioned, that's what the infrastructure is there. So we can help you design that appropriate trial and get the grant in.
The thing I would add, the other opportunity that I would suggest, even separate from your protocol, is some of you are at sites that are in one or more of these networks. We have opportunities, when projects come in, a lot of this development, there's what we call a NeuroNEXT protocol working groups, and it's probably similar structure in the other networks, it's the same terminology, but we're looking for experts on that. And so if junior people at the network sites want to get involved, particularly if it's something in your disease area, it's very useful. It's not that different from the discussions you've seen in your small groups, but I think it's helpful to see how all these pieces get pulled together, really on kind of the next scale, outside of your protocol, but on a multi-site level.
I sort of have a parallel question about how to use the networks. How about funding mechanisms for these sort of 1 or maybe 2-site clinical trials that are really early in development, not quite ready for the next stage of using the clinical trial networks? What's the best funding strategy for those?
So your question is funding strategy for things that aren't quite to the point to go, maybe
Clearly, it would depend on the specifics of your study, but if you're in a phase where you're really early in training, it might be a training award, but if you are Also, working with advocacy groups, there might be foundations that are interested in giving you money, or the AAN for seed money to do pilot studies that could lead into one of the networks. Or there is an exploratory clinical trials, PAR, that was on my first slide. But the bar is very, very high, so you need some pilot data before you go into that. But we can talk further about the specifics of your idea. I know that you progressed.
So my understanding is one of the goals of this network is to facilitate IRB approval. But at least I have encountered that doesn't have a central IRB, and then each institution wants their own IRB and process approval. Is there any mechanism to try to uniform, have just one central IRB and have each center to go through their own IRB? Or
So I'll let Dr. Meurer start talking about central IRB, although NeuroNEXT also was early in that.
Yeah, NeuroNEXT was actually a leader in that, and that they built in the requirements of sites seeding into a central IRB that was paneled at Mass General into the awards to the sites. And that was also sort of generalized to really a trans NIH policy for multi-center research, and that any multi-center research is required at NIH to go through a central IRB. Cincinnati also was the central IRB for StrokeNet, and we've been having interesting experiences with that. For SIREN, the central, we have our, now we have a central IRB. We use a commercial IRB called Advera, and in this setting with the BOOST trial, it's the first time we've used a central IRB to do an exception from informed consent trial where patients in an emergency situation are, at least in the academic space, you have to do community consultation and have procedures to get in touch with legally authorized representatives. But because the BOOST trial, which is of intracranial monitoring for severe TBI, does require some interventions to occur quickly, you may not have access to a legally authorized representative before treatments need to occur. And we did do a submission in StrokeNet for a pre-hospital stroke trial that was going to have EFEC and would have used the Cincinnati Central IRB. So there's been, but that's a really long way of saying that if you're doing multi-center research, the NIH and it's funded by the NIH, you're required to have a central IRB or a single IRB. The policy is single IRB. So if you have 3 centers like Iowa, Minnesota, and Nebraska, let's pick kind of like Central Big Ten, I guess, or Western Big Ten. Like you would, one of the, probably the submitting institution, the others would basically one of those institutions would need to be picked as the IRB of record for the entire study, and the other sites would cede to that IRB. Now, one thing that I will point out is that we think of IRBs as doing lots of things. At Michigan, they do the IRB application, involves a lot of stuff, which isn't the ethics review, which isn't the protocol review, which is some of the vetting of investigators and some of those other things. Some of that is handled by a central IRB, but some of those internal processes of routing are not actually federally required IRB functions. They're just administrative steps within your institution. So this is probably going too far into the weeds. So some of those things, they still have to happen, but in terms of an ethics review, your IRB is not going to conduct sort of an independent ethics review of the protocol. Is there, you want to add anything on that?
The only thing I was going to add is one of the advantages of the network, particularly I think for you guys as junior investigators, is even, so now all NIH multi-site things have to have a central IRB. So if you created something, example, will be Iowa or Minnesota, Nebraska, or what was that? You would have to kind of, central IRB, you have to put the structure in place. One of the advantages of the networks is that there are alliance agreements that exist with the central IRB kind of at the network level. There's also master clinical trial agreements that exist at the network level that basically take care of the legal aspects of that, right? The protocol still has to go to the central IRB, but all of the, if you guys, in your experience, have had to negotiate contracts at your universities, that can take forever when you get lawyers at 2 different universities involved and you're sorting out language and getting all of that. Having all of that in place takes a huge logistical hurdle already off the table that's already in place with the network. So, when the protocol's ready, the protocol has to be reviewed by the IRB, but the reliance agreements and, even outside of the IRB, with the contracts that allow for money to pass through the various institutions is already in place. So, that, and we kind of look, comparing the data to pass, and yes, I think we can save anywhere from 6 months to a year just in avoiding, the 1 or 2 sites that can drag out. And, in the old days where that had to be done at every site, every study, there were a lot of delays in recruitment just tied up with contracts and things like that. So that's another advantage of the network, but particularly if you're young and never gone through that before, having that help and not having to do that can be a huge advantage in terms of getting the study quick, which is the ultimate goal of getting people recruiting into the study, getting the study finished, and getting the results out.
I thought it would be useful for each of the participants to talk about a particular success in the network they've worked in and how it helped to improve data quality as well as efficiency.
So I guess I can talk about the NET and the SIREN would probably be the best ones because I've done a lot of trials in those 2 networks. We had the Rampart trial, which was the first trial, one of the first trials that the NET network did. And we learned a lot from that because that was exception from informed consent. But what we learned from that trial, we were able to carry on to the future trials that had exception from informed consent. So that was very helpful. The other trial was the SHINE trial, which was a stroke study that the NET did. And this one was related to glucose monitoring for folks that aren't familiar with the trial, but it was with continuous glucose monitoring by the bedside versus sliding scale. And just the manpower to get that trial together. We had 56 sites, we had to enroll over 1,200 patients. But to get the manpower of how do they use the device, how do they get the device at the bedside, the nurses, it's not just study coordinators, we have to think of the ICU nurses and so forth, and just putting all of that together to have a successful study, actually from the beginning to the end. I don't think we could have done that study without having the support of the networks and this experience and the expertise in the room. It's really a multidisciplinary approach, but to see that from the beginning to the end is pretty amazing. So don't get discouraged if you feel like you are never going to be able to get that trial up and running, because that's part of what the networks are for, is to help you figure it out and come up with all the different logistical challenges and found solutions to those challenges.
So I guess if I had to pick one, I'll maybe tag on to like something that was mentioned in Eric's talk last night, the spinal muscular atrophy and the first approved drug that came along. So part of doing science, it helps to be in the right place at the right time, right? You kind of make your own luck, but sometimes luck into it. So the first study that was funded in NeuroNEXT was a spinal muscular atrophy biomarker study, which was looking at longitudinal assessment of like muscle outcomes in infants diagnosed with SMA in the first 6 months of life. So this is a very sick population. It was, I would say it's probably the most depressing study I've ever worked on because it has a high mortality rate. So half the babies with SMA in the study died before they reached the planned 2 years of follow-up. But the bright side of going through that, right, is that the data as we were finishing the study, that biomarker data was coming out around the same time that the drugs were being sent to FDA for review. And so one of the things that was indirectly tied into that, but was like I think a nice thing that the network could contribute, was we were able to share that data with FDA during the review to kind of calibrate the placebo group in the trials, because you don't have large numbers for that. So that helped, I think, to provide additional evidence to see that come out. So it was like very much, it was forked off by NINDS to have funded it, but it was the perfect timing for that to come out. I think in terms of the data quality efficiency thing, it's kind of a good example, though, of where the world of clinical research and clinical trials is changing, and that we're kind of in the age of data sharing, right? Where the idea is when, in the old days, trials would finish, the PI would hang onto the data, you might ask them, they might find it, they might give it to you, they might not. Now you're required to data share. And I think, the process of that, going through sharing it there, sharing it in the NINDS repository, has led to changes, I think, that we put internally, in that you have to think earlier on in building your database and building the structure of your forms, how you would share it at the end, and thinking of, you know, what you can vet, what you can't vet. I mean, nothing's ever going to be perfect, no matter, you know, the complete data cleaning plan is going to be impossible to do, but at what level to do it. I think that's helped us, you know, by putting things in earlier in the process in terms of sharing things at the end, that have actually led us to, I think, be more efficient as we've gone through, you know, additional studies that we've gone through. So that's one of the exciting things.
I think one in the NET network, the established status epilepticus treatment trial, which should be coming out in a medical journal near you soon. But this was a trial for patients with status epilepticus who had not responded to benzodiazepines. And in terms of second-line treatment, the three things that we could, and we actually planned this during the Adaptive project, which was a joint venture between FDA and NIH to bring innovative clinical trial designs into the confirmatory trial space. And it was really neat that we planned this trial. It involved adults and children, which I think was a really unique contribution, because adults and children have seizures. And too often we kind of sit in silos and don't test treatments in full populations. But we had to there was an exception from informed consent trial. People are seizing, we had to figure out all the logistics of how do we assign the bags of drug across different groups, and you know, change randomization ratios, lots of logistical issues that I think really represented the best of collaboration between our group at Michigan and MUSC and the partners across the sites, partners from area consultants in terms of some of the design work and setting up the programming to do the simulation. So I think ESET represents you know, one of the I mean, all of the trials came to, you know, very important answers, including SHINE, which will also be coming to a medical journal near you soon.
It's out.
Oh yeah, it's out. It is out today. So I'll hand it over.
I guess I would broadly say that, frankly, the whole experience so far, I think that Will and I both grew up, frankly, in this network era and in this sort of team science era, and don't know any difference. And so my very first foray was when Rob and Bill Larson were writing the sort of clinical coordinated center grant for NET. I put together this table that was in the sort of right-hand corner of the very first sort of significant section. It was this little table out of 200 pages of material. And that was my contribution of the burden of neurological diseases, emergency neurological diseases. And so from that then, sort of participated in the network, participated in all these trials that we've been discussing, participating not in adaptive per se, but certainly watching from afar and learning about adaptive design, and Roger and Will know way more about that than I do. But that then led to most of the trial that I'm involved in, which again is an adaptive design, 2-3 type design with milestones along the way. And so the experience for me has been, again, from my notion of literature search to create this table to being PI on one of those trials. And so the whole thing has been pretty remarkable. Back to your question about at what point you should be involved or not involved, I would say you go from the little table, which again may not have anything to do with what you're interested in per se, but that table sticks out in my mind as one of the things that I got to participate in the larger course of what it is that we all do. And then subsequently be inside PI on multiple clinical trials that again isn't necessarily part of my primary interest. Lori, for example, I know was PI for one of our stroke trials, which is not anything to do with her primary area of expertise. But if you think about it, you still gain this hands-on experience, you still gain this knowledge that contributes to your overall development. And So that's what I would say has been the greatest part for me.
I wanted to add one thing about the SMA study that gets back to the original question you asked at the beginning. Is so the PI of that study was Steve Cole, who's at Ohio State. And so before this version of the course, there was a Vail version of this course that existed before. And Steve actually was a student in the Vail course who then led that study in NeuroNEXT. It wasn't tied to his project, but that's one of many examples of people who have done the course who have gone on to be some of the site PIs for former students of the course. Mike Benatar is a good example of one, and there are others. So I think there's kind of a long pathway of not just individual projects, but growing into clinical trials and even beyond.
Thank you, those are great points. I also wanted to say, I believe you were both junior, assistant professors when you first became involved in the networks at the very beginning. So it's not as if this is only for senior people. And I think with our education program, we're really trying to bring in junior people sooner and get them involved and, give them wings so that they can learn how to be site PIs in the next generation. That's something that Dr. Wu and Dr. Dutton has worked very hard, and Dr. Quick is now working on. And so I think those are really important pieces. Does anyone else have any questions?
For stroke and neurocritical care-related trials that are in very early stage, can they go through NeuroNEXT, or they have to be specifically part of SIREN or StrokeNet? Because they're not really, they're very early stages, stage 2, phase 2. I'm sorry. Oh, is it for neurocritical care and stroke trials, if they're in very early stage, phase 2, can they be part of NeuroNEXT, or do they need to go through StrokeNet or SIREN?
StrokeNet does phase 2.
Okay, so can it be just in very early stage and still be part of the StrokeNet?
Yeah, I should make that point that initially NET was undertaking stroke trials that were phase 3, but when StrokeNet started, all stroke trials have to go through StrokeNet. So that is something good to remember for all of you in the audience. And then as some of you have ideas for stroke trials, and we want to encourage that. I know that StrokeNet seems daunting, but there may be ways to get your foot in the door. So, Dr. Meurer?
I would just add, if it's something that's like 1 to 3 centers, then the exploratory trials that Dr. Conwit mentioned potentially is something that could actually go. That wouldn't necessarily be a StrokeNet trial, but I think it's somewhere around 5 or above number of sites it would need to go to StrokeNet. So that being said, though, you have to think about what the benefit of having 3 sites is versus something you could do with one very highly motivated site in terms of having to wrangle the additional sites and so forth. Unless you live in a pretty dense region where possibly you have 3 hospitals and can share resources, teams, and so forth. But 3 distant sites for that sort of early phase trial, I think, would be a challenge. I would also encourage you, this exploratory trials, FOA, NINDS, has been for sort of either, has been around for a bit of time now. And if you go to Project Reporter, you can put in specific FOAs and look at what has been funded through that. You don't have a sense of everything that was submitted to it, and as Dr. Conwit alluded to, they're very rigorous in terms of the trials that they're looking at. But still, these earlier phase trials are the substrate from which the networks are prioritizing and deciding on what to do next. So, but yeah, don't be daunted or discouraged. And it may be that even going through the network process, if you're on the edge, they can teach you so much about how you could be thinking about what questions you might need to answer and come back with from your single site type study first. So again, StrokeNet is quite busy in terms of preparation and planning, so it's something to consider.
That's a great point. And I just wanted to say that you do need pilot data before you come into the exploratory clinical trials FOA. So sometimes it's really beneficial to start with a foundation. And I know a lot of people want NIH grants and they're not interested in foundation grants, but a lot of careers have been launched that way, and I think you need to be open-minded, and Dr. Hartman is nodding his head. Do you agree? Yeah.
Strong. Girls, closing.
Yes, please. Comment.
Whatever it says comment, she wants to answer. So I was actually at a private foundation, a patient-based foundation conference last week, and they to use a dish where they were excelling over how successful some of their investigators have been, and they just love saying you're a part of the success story early on, and and then they can turn around and say to potential donors, look at what your small investment has done. You've loaned up to this person who's now getting multi-million-dollar grants from NIH. So it's a feather in their cap, and you actually get to know people in their community, which I think is a tremendously beneficial thing. So I think it's a force multiplier, and it's really, really important. So take their money, they want to give it to you.
And we've had panels before where we had representatives from the various foundations, and they came and talked to this group, and we can try to bring that back if you think that's useful. Now, I think to put you guys on that, I'm going to ask Dr. Shai and Dr. Benatar to comment about their networks and the training of subjects, fellows who have done very, very well.
Thanks, Robert. So I'm just trying to think of a way to summarize it, but I lead what's called the Inherited Neuropathy Consortium, which is up to 20 sites around the world that investigate inherited peripheral neuropathies. And one of the things that's been most satisfying is the number of young investigators who come into the field, learn how to develop natural history studies, and also through courses like this one, learn to develop clinical trial design, and a number of these have already gone on to become leaders in our field at the moment and are the next generation. So I think this kind of interaction where they can also get training not just from a person like me, but from others like PIs around the world who are leaders in the field. I think the networks offer that potential to allow people to really access knowledge and grow very rapidly.
Okay, Dr. Benatar is on our advisory board as well.
So we run a consortium of rare diseases network focused on ALS-related disorders, and like Mark, I think we're also less focused on clinical trials immediately. And a lot of our work is natural history, biomarker-based. But we do, as part of these programs, all have training components built in and funding to help support young investigators working in these areas. And so we try to release those RFAs, those funding announcements as broadly as we can. We actually have an evolving partnership at Robin's suggestion with the American Brain Foundation to get those out more broadly released. But for those of you working in these diseases that are part of the Rare Diseases Network, there may be additional training opportunities.
Thank you all. Are there any other questions from the audience? Roger's scratching his head. I think our time is up, but